if you are over 40 and you've been postponing that breast mammogram, this is your sign to schedule it now. Okay, at least wait till the end of this episode, and then I want you to schedule that. Many women know about breast cancer. We have a whole month dedicated to breast cancer awareness, and there's a lot of advocacy around breast cancer and breast cancer research because it is so prevalent in women. But here's the thing with early detection, it is also so curable and treatable. That is why having a yearly mammogram for so many women as a screening tool is so important. And you don't want to be like me and forget to schedule it. And next thing you know, 3 years have gone by. I'm so thrilled to have Dr. Angela Malik on this week's episode. She is a breast imaging and interventional radiologist practicing in the DC area, but she is also a huge advocate for women and the importance of early detection and breast mammography. Now, she is going to help dispel some of the myths associated with mammograms, why they're important, and kind of walk us through what we can expect when we go for our appointment and get the mammogram. Because I know I was hearing horror stories prior to my first one and thinking to myself, I'm not sure I really want to do this. If you are approaching a mammogram, perhaps for the first time, or wondering if you really need to do those monthly self breast exams, this episode is for you. Let's get into it. Dr. Malik, I am so glad we are able to connect because I know there, just like with skin, women, especially in midlife, we have a lot of questions about our breast health. So thank
Yes.
you so much for being here.
Yeah, absolutely. Thank you for having me. I agree. There's a lot of overlap.
Oh my gosh. And a lot of misinformation. I feel like there's this, like, at least in dermatology or skin health, right? There's this like sweeping tide of misinformation that sunscreen causes cancer, all
Mm.
these things cause cancer, right? And I'm also seeing it with breast cancer, right? Like now I'm seeing people say mammograms are unsafe or they shouldn't be getting them. So I would love to hear your thoughts on mammograms. Should we be doing them? What do the guidelines say?
Absolutely. So mammograms are safe, and the guidelines per the American College of Radiology and the Society of Breast Imaging are that average risk people should be getting mammograms starting at the age of 40 and annually. We know that decreases the mortality by 40%. So what is average risk? That's the 1 in 8 over the course of our lifetimes, which averages about 12%. How do you know what your risk is? We also recommend that a risk assessment be done by the age of 25, definitely no later than 30, with your primary care provider or gynecologist to determine what your risk score is. And that'll help guide whether you can start at 40 or whether you should be starting earlier, perhaps at 30. And it can also guide if you should be getting genetic testing. In terms of mammogram safety and why we're seeing so much misinformation, of course, mammograms, involve compression and they can be uncomfortable for some people. But really, what I think the main source of the misinformation is people who make money off of misinformation. So those who are touting alternatives and directly being paid for those alternatives. So when I tell someone to get a mammogram, they're probably not going to come to my clinic. They're probably watching a video from 10 states away. So I'm really doing this, quote unquote, for free. I make no money off of my recommendations. And so you can really trust that, I am an expert. I have the credentials to back them up, and I'm recommending what the guidelines recommend. So,
Yeah, no, 100%. I always tell people, like, if someone's telling you, don't use this sunscreen, then what are they telling you to use, right? And is
right.
it something that they happen to be selling, right?
Great.
Or some sort of alternative treatment. So, it's kind of sad. But really, especially in this day and age, it's really like buyer beware. So, be careful what kind of information you're consuming and then sort of like look for their angle. Like, are they suggesting I do something or pay money for something else? So I love how you mentioned that. And yeah, I just told my patient, damn, like, put me out of business. Like, start
Yeah.
wearing sunscreen and I'd be happy. So yeah, because I don't make money by telling you to wear sunscreen. It really am passionate about reducing your chance of skin cancer, just like you are with breast cancer. And yeah,
Absolutely.
that early detection, again, just similarities with skin stuff is so key, right? Because with early detection, what are the survival rates for women with breast cancer?
Yeah, so great question. So, part of where annual mammography reduces the mortality is by catching cancer early. So, for stages 0 and 1, it's about 100% chance of survival at the 5 year mark. Whereas those numbers drop to somewhere in the 40 to 60% range when you're talking about metastatic breast cancer. Now, every breast cancer is different. So some cancers present at the metastatic stage, and no one is to blame. But the concept is that if you are getting your screening, there are certain types of cancers that we can catch early, prevent from going any further, getting any further. And also, it's not just about, I mean, it is, of course, about, the stage and what we catch it at, but it's also the types of treatments that you can get. So you can get a smaller surgery. You might be able to avoid chemotherapy. You could have better, cosmetic outcomes, which they do matter, right? I mean, how we feel about ourselves ultimately does affect our day to day. So all of it matters. The outcomes are most often going to be best with early detection.
Yeah, totally. And I'm talking about women with breast cancer. Obviously, there are a subset of men who can get breast cancer, but I know for women, right? Like it's so much our identity as women to have breasts, right? And then especially back in the day when they were doing these very aggressive bilateral mastectomies and women are losing their breasts, it's really traumatic. Then they also lose their hair with a lot of the treatments. And I feel like that is like losing a part of what makes you a woman. So it can be really psychologically detrimental for women.
Absolutely, and we're so lucky that we're in a day and age where we have so many treatments at our fingertips. And also just, so much has evolved in the conversation. I actually have friends that have gone flat, just completely, no nipple or skin sparing. They've just said, "Take it all. I don't want to deal with it." A lot of those are genetic mutation carriers, so they've had a little bit more time for the forethought of what they want to do when they take those prophylactic measures. But yes, we're not slicing and dicing the underarm area to take the lymph nodes, for example. There's a lot more careful approach to that so that patients aren't suffering from lymphedema in their upper extremities where the fluid is unable to pass. And we now have cold cap therapy, for example. And you might, as a dermatologist, be more familiar with that. But I in fact saw that New York State might be mandating coverage for cold cap therapy, which does help um, those who are on chemotherapy retain their hair, which again, I mean, it has such a psychological impact on those who are going through, surviving and thriving and just doing their best, and any little thing that we can do to help them, which for me, again, is early detection and advocacy, it really does have an impact.
Amazing. Yeah. So, kind of walk me through someone who is maybe scheduling or preparing to have their first mammogram. Because I know I was scared. I have to be honest. I was like, this sounds really uncomfortable. Everyone's telling me these horror stories about, their breasts being smashed and pressure and all that. So, kind of walk us through what that looks like and maybe ways we can prepare for it.
Sure, absolutely. So number one, I always recommend to patients that if you have a standard cycle, or through your IUD, you can kind of tell when you may or may not be feeling a certain way. It is a good idea to get your exam mid-cycle. So if you have a 28-day cycle, the first day is when you bleed, the last day is before your next bleed. Try aiming for mid-cycle, and that's when we are, in theory, the least hormonally influenced, and so you're sort of getting a head start of decreasing any possible associated pain from a mammogram. I recommend that you wear a two-piece outfit because you are gonna be taking your top off, and so, sometimes it'll just make you feel more comfortable to have your own bottoms. We do have dress length gowns, but, it's just something to add to the experience for you to feel a little bit more secure and comfortable. We ask that patients do not wear lotion or deodorant, and it's not related to any safety or interaction. It's because the skin can kind of hold those particles. So, when you put your deodorant on, you might see that white streak. And that actually embeds a little bit in the skin and it creates a lot of artifact. So the image is not as clean, and it can make it harder to detect cancer. So we either ask patients not to wear it or to clean it off.
Sorry to interrupt, but I'm glad you mentioned that because I remember thinking like, "Oh, that I don't really need to do that," you know? So and then you told me you're like, "Actually, you do."
Right.
So, thank you for explaining why we need to do that for people who are a little more stubborn like me.
Exactly. Now, one thing you don't have to worry about is underarm hair. That's your own. If you want to shave, that's fine. But the same as the gynecologist, we do not care. We do not judge, and it does not affect your picture. And then for the exam itself, you're going to be giving a lot of family history and personal gynecologic history. So things like when did you first start menstruating? When was your last menstrual period? Your pregnancy history, your family history. So again, it's good to have those conversations, not just about breast cancer, but also for ovarian, colon, pancreatic, um, and some of the other melanoma and thyroid. So we're going to be asking this whole series of questions, and that's because in addition to the mammogram pictures that you'll be getting, a lot of places are calculating risk scores so that you're getting that updated risk score every year to know if you need to change your management. For the images yourself, your technologist will be helping position you in the machine. Sometimes it can feel like you're getting a little, manhandled, but they're really just trying to get all that tissue in there to make sure that they're getting the best images possible, to get everything compressed and pulled in so that there aren't any technical repeats or false positives from tissue that wasn't completely compressed and maybe mimicking something more concerning.
I'm just gonna interject. I've always had really sweet techs who help me, but yes, it can feel like you're becoming a contortionist just a little bit, right?
Yeah, no, absolutely. I mean, look, I joke with my technologists who like are excellent at what they do. And I'm like, I don't know what I've ever done to you to make you do this to me. Like, and if you're not doing anything differently, and they're always like, oh, Dr. Malik, you're so silly.
That's right.
But yeah, I mean, it's not easy, but it is quick. So
You're right, and, the better, the more helpful you can be to, like, really just get it right the first time so you don't have to go back, like, that's always my inspiration is, like, let's just do this once and not have to repeat it.
absolutely. And you know what? Like I feel the same way about my pap smear. I'm like, it's just quick. Like, let's just get it done. I've had skin biopsies. None of it's fun, right? I mean, colonoscopies, none of it is fun, but it's meant to be life-saving. So you just have to just sort of have some perspective. So for the mammogram itself, the standard is 2 views of each breast, one from top to bottom and one oblique side to side. Of course, based on your breast tissue, there might be extra views just to get all of the tissue in. But the standard mammogram is 4 views total. And then you will get dressed. And typically, you're going to get a letter in the mail anywhere from, a week, 2 weeks. And it'll include your density. So that's a federally mandated guideline that you will have your breast density in your report. And again, if your facility is calculating risk, it will talk about that. And then also some facilities are reporting breast arterial calcification. So that's looking at the blood vessels in the breast, the same as how we can have calcium anywhere else in the body, what we call atherosclerosis. We look at that in the breast as well. There have been some studies showing that it can be an early sign of coronary arterial disease and is particularly useful since we might be seeing it in women at ages younger than when they're getting cardiac screening.
Yeah, very interesting. I don't think I've seen that report yet on mine.
Yeah, and it's not universal yet, but I think in fact you're in Georgia, right? I think Emory was part of a big study. My facility does it. I know Mayo did a study as well. So I think it'll be happening more and more. It's not universal yet, but hopefully it will become so.
Yeah. So, okay. So after you do the mammogram, right? Because I think people may know you don't actually see Dr. Malik when you're getting the mammogram, right? But then you're going to be looking at those images. And then what happens if there's something? Because I've gotten a letter where it's like, you got to come back in. We saw
Right.
something. So what is that about? Because that can be really nerve wracking, right? Because you're like, oh my gosh, what's going on?
Sure. Yeah. So when we do any kind of screening exam, so That's to include a TSA screening at the airport. You're either going to be all clearing, your bag gets to go all the way through, or they're going to say, "Oh, we saw something," right?
That's
And
right.
with me, it's going to be my hair straightener
Oh,
or my
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 dry
mom's
shampoo.
food. Right. Oh, that'll do it. Or my mom's food wrapped in aluminum foil, like the Indian food that's like been wrapped with love, gets called every time. And I tell them I know it's my mom's food, so yeah, so it's the same concept, right? Where something just looked a little off on the image and we just have to make sure. So same with the airport. It is probably not going to be a weapon or something dangerous. We just have to make sure. So the numbers that I like to give for perspective, if 1,000 get a mammogram, 100 to 200 will get called back. So they'll get that letter and that phone call that say something doesn't look right. 20 will end up getting a biopsy out of all of those that are those 100 to 200 called back, and 5 of them will have cancer. So first of all, if you're out of the 1,000, the numbers are on your side. But even from that 100 to 200, the numbers are on your side. And hopefully, if you're one of those 5, it was detected early and you'll still go on to be fine. So most callbacks we know are going to go on to be nothing. It's either overlapping tissue, a change in the breast. In the days of GLP-1 inhibitors, we see a lot of weight changes, and that's going to have a huge effect on your mammogram because one of the things inside of your breast is fat.
Yeah.
So if all the fat goes away, we're going to have a huge change in the breast, or vice versa if there's weight gain. And of course, we were mentioning in midlife, right? So, in menopause, there are a lot of changes. Perimenopause, there are a lot of changes. So we just have to keep track. We're just like TSA. We're gonna get that hair straightener every time.
Oh, yeah, and those nail clippers, but you guys are a lot nicer.
Yeah.
Although, actually, I shouldn't say that. I would, 'cause there could be some nice
Okay.
TSA people. That's not
Yeah.
nice of me. But yeah, I've definitely been called back, and it's nerve-wracking. So can you kinda talk to us a little bit about dense breast tissue? Because I think we hear this word and we're like, "Okay, is it good? Is it bad? Does it mean anything? What should we know about that?"
Yeah. So, nothing is good or bad. It's just who we are. And so everyone's breasts have a different proportion of fat to fibroglandular tissue. So everyone's breasts, no matter how big or small you are, have both components. And we, through the American College of Radiology, came up with a system to classify the different proportions. So it's 4 categories. It's entirely fatty replaced, or predominantly fatty replaced. It's scattered fibroglandular densities, heterogeneously dense, and extremely dense. So these last 2 categories are the ones that fall into the dense breast tissue. Now, they are most relevant for 2 reasons. Number 1, it is going to be harder to find cancer on those mammograms. The reason being, a mammogram is basically a black and white x-ray of the breast. Even in these 3D ones where we're taking multiple images, it's still black and white. And the white is the tissue, and cancer shows up as white. So the more tissue that you have, the harder it might be to find. It's like a needle in a haystack, basically. And then the other reason it's relevant is it can increase the risk for the development of breast cancer. So extremely dense breast tissue, that 4 out of 4, is actually a 5% relative increased risk. So I've seen people go from essentially average risk, right? Like around 15%. We said average is 12. And just having extremely dense breast tissue bumps them into the 20% category, which is considered high risk. So we know it could mean that people need supplemental or high risk screening based on their density. And many states, including all the ones I've worked in, have been reporting it for over a decade. But as of last year, the FDA mandated nationally that it be reported.
Okay. So, what are some of the ways that you might image dense breast tissue if it's not with a mammogram? Are there other modalities?
Yes. So, well, first of all, not every mammogram is the same. So, while 3D mammography is very, very common, there are still places where 2D mammography is the standard, or there are some insurance providers who will not cover 3D. It is rare, but it still does exist. So, if given the option, you absolutely should be choosing 3D mammography or breast tomosynthesis. Those are the same thing. Um, Decreases callbacks, increases cancer detection. So it is better. We know it. And then the 2 options for supplemental screening are ultrasound or MRI. So mammograms are x-rays of the breast. Ultrasounds are using sound waves. It's the same thing as when you're looking for, the baby for an OB ultrasound. And then MRI is using, it's non-ionizing radiation. So it's actually using magnetic waves. And there is contrast administered through an IV. So it's one of the many vascular tests that we have. So if you think of like a CT scan, which might be more common, or you've seen it on one of the hospital shows, anything where you're given something through an IV, it's taken up in areas of increased activity. And so it is thereby better than what we call anatomic imaging, which is what mammograms and ultrasounds are. So the numbers that I like to share with my patients are mammograms can detect 6 to 8 breast cancers per 1,000 screened. Ultrasounds can add 1 to 2. That's when they are done with the mammogram. They can add an additional 1 to 2 breast cancers per 1,000 screened. MRIs can detect between 16 and 17 per 1,000 screened. So the numbers speak for themselves. They are a fantastic modality. But due to the limitations, they are still best for high risk or supplemental screening. So what I mean by that is like screening needs to be something that you can do on everyone. It needs to be quick. It needs to be cheap. It needs to be easily interpreted, easily performed. And most people need to be able to tolerate it. So an MRI, for example, it's expensive. It takes longer. People might not tolerate the contrast. A lot of people can't tolerate the claustrophobia or have mobility issues. And for a breast MRI, you have to lay face down. So it is a great imaging modality, but it's just not one that we could do on everybody. So it's, still being reserved for high risk screening and supplemental screening.
That makes sense, and thanks for kinda breaking that down on, like, the order of operations on what you should have and what should be done. 2 last quick questions for you. What about implants, right? I feel like I've heard that it's actually maybe could be helpful for looking for breast cancer, and then other people say it can sort of obscure breast cancer lesions. What are your thoughts on it as a breast radiologist?
Yes. So number one, people with implants can get mammograms. Of course, there is always a risk of rupture. That is more common or most common with older implants. Like if they've been placed a long time ago, they're already at risk for rupture. The newer kinds of implants, particularly silicone gel, are much sturdier. And I know plastic surgeons who have shown what happens if you even like cut into those implants. The gel does not like leak out. It just sort of is like one of those squeezy toys that kids have. So
It's actually pretty amazing.
yeah, it is very cool technology. But point being that mammograms are safe and they can be performed on people with implants. Now, we know that there are different positions that implants can be. They can be behind the muscle or they can be behind the tissue. So that's retro or pre-pectoral. Retropectoral, of course, is going to mean that we still have all of that tissue. The problem being that, some people's implant, it's just really hard to separate it from the tissue. So when the technologist is trying to push the implant back so that you just get the tissue, we know that there's a possibility of missing out on some tissue, particularly in the bottom of the breast, the top of the breast, and the sides. And certainly if you're prepectoral, there's always a risk of some tissue being missed. But in those situations, you can talk to your plastic surgeon, talk to your radiologist about whether you also want to be adding MRI. Again, to be looking at that tissue that might be missed. So just talk about what the options are.
Yeah, well, great. And our mammograms, is this something we're gonna be having for the rest of our lives, or is there a cutoff age where they're like, "Okay, we're not gonna make you twist like this and get your mammogram every year?"
Yeah, another good question and one that's like always debated. So the American College of Radiology does not have a cutoff age. It's more of a discussion. We believe in shared decision making too, right? Like we have these guidelines, but your body, your choice. So we recommend that they be obtained every year until a 5 to 10 life year expectancy. So, if you're someone that's on home oxygen, I don't think mammograms are gonna, breast cancer is not gonna be the biggest problem if you're in heart failure, things like that. So those are conversations to be having with your doctor. But if you're otherwise very healthy, which, life expectancy, I've seen plenty of very spry 90-year-olds who do not have time for breast cancer, let me tell you. And so, yeah, so they're coming in there and they're getting their mammograms and they're driving themselves to their appointments. I mean, so Again, it's going to be a very individual decision on when you stop. And if you do stop, then it's very, very important to be doing self exams and clinical exams because I so often see patients who haven't gotten mammograms for years who present with these huge tumors. And then it just becomes this whole thing because they're not a great surgical candidate, but they're not a great chemotherapy candidate. And it's really hard for all involved, of course, the patient the most. And so we really want to be avoiding those situations and still keeping an eye on things.
Great points. And yeah, I kind of like because I do want to maybe have you close us out with how to do a breast exam, right? And why we should be doing them. Because I think it's not just, and I'm guilty of this too, right? Like we forget and we're like, oh, shoot. And I know I tell people, look at your skin once a month, right? But we should be doing these breast self exams, right?
Yes, absolutely. So the recommendation, same as how I said for your mammogram. If you have a regular cycle, aim for mid-cycle because again, that's when we're the least hormonally influenced. So we do recommend self awareness. So it's not your job to know if this is a lump or a bump. It's your job to know if it's new for you. So if you get a feel for your baseline, then you can know when there's a change. So we always recommend that the arm be back for it that pulls all the skin taut. So whether you're laying down or you're up in the shower or you're up in front of a mirror, I think a mirror is good because you're also looking at the skin and the nipple for a breast exam. So, it's not just feel, it's also visual. You want to be sure that you are going from your right under the collarbone to below the breast. You want to go from the sternum or the breastbone over to the side to include your underarm. I recommend using 2 to 3 fingers and, going towards the nipples so that when you're rolling, if something, like, actually persists, you get an idea of, like, is that a real lump? Or, if it was just normal tissue, like, if you put your finger on something, it might feel lumpy, but then, like, you can kinda tell the difference. I certainly can, like, sometimes when patients come in, I'm like, "That definitely feels like a rib." I put the probe down, I'm like, "It was your rib." It's okay. A lot of people come in for ribs, but if you, like, actually they do, I mean, because it's like
But you know what? I'm glad they're doing their exams, right?
exactly, and again, with all these weight changes with the GLP-1 and everything, I mean, we're seeing all it's fine. Um, you also wanna be paying a close attention to the nipple and the skin, looking for any skin changes, areas of redness, nipple flaking, itchiness, and just reporting those symptoms. One thing I also recommend is that if you do identify something, this isn't a, go to the doctor next day kind of situation. This is a watch it for a week, once a week for a full cycle. Now, if it's getting bigger, you go to your doctor. Like you don't have to wait for the full cycle. But if it goes away, or it's getting smaller, it's definitely not cancer. So you can bring it up at your next annual. But it's most important, again, to be aware, right? So you can say, oh, I went back to my baseline. It's not something that we need to, it could just be your normal hormonal fluctuations. The sort of party line, if you will, on self exams and clinical exams is that while we know that majority of findings on self exams and clinical exams are not cancer, so are what would be considered false positives, the same as when we call someone back. There are still so many people who find their own breast cancers, either because they're not of screening age or they're not getting screenings or because they have an interval cancer. It doesn't mean a mammogram missed it. It means it truly came between mammogram A and B. So it's especially important if you're not of screening age. I mean, it's important at all times once you are of reproductive age, but if you are not of screening age, it's exceptionally important because you are the only one that is going to find your cancer if we're not seeing you.
Yeah. I could name 2 women about my age right now who found their own breast cancer. So, yeah, it just shows you how important that screening is, kinda get to know your breast tissue and,
Absolutely.
as you get older too, these skin growths can pop up on the skin or cyst in the skin. So it's important to kinda be aware of those, know your body, and it just yeah, will just help you along. So I feel super empowered now that I too can need to start doing my self breast exams and feel super confident about getting my mammogram. So Dr. Malik, thank you so much for sharing all this with us. You have a lot of great content on social media. I know people are going to want to find you. follow you, learn from you, what's the best place for them to do that?
So at Anjali Malik MD on all socials, Instagram, TikTok, or you can check out my website, anjalimalikmd.com.
Amazing. I will include all that in the show notes, and I so appreciate you being here. Thanks so much.
Thank you for having me.
We'll see everyone next week.